Thanks very much. Open for questions now. While we're waiting, I can start with one question. I'm wondering if the panel members can address in a little bit more detail the tension between the importance of implementation, fidelity, and adaptation. Because I'm sure we've all experienced that most users of these evidence-based practices want to adapt them, think it's important to adapt them, yet we know that implementation fidelity is highly related to outcomes. Luanne addressed this somewhat in her presentation, talking about guided or planned adaptation, but I wonder if we can elaborate on that and give some additional insight into how we balance these two goals. It's a hard one.
Just a couple of comments. I could go on and on about experiencing this tension, but one thing that we talk to our communities about, and I'll just be upfront, on the continuum of adaptation and fidelity, I'm definitely a hardcore fidelity person. But in CTC, one nice thing is that there's so much planning up front before you before you implement a program. The consideration of, okay, hopefully you'll have some programs that you can choose between to address your needs, and to look really carefully right from the outset at the requirements of those programs, and to assess, could I implement this with fidelity, rather than just grabbing something and not finding out until you're in the midst of it that this is more difficult than I thought. I don't have the resources to do this. This doesn't fit my agency very well. So I think one problem is communities don't always take the time up front to think about what they're getting into, and then you're stuck trying to reactively, fix the problem and cut corners. So that's one way of trying to avoid the problem from the get-go. So I might just leave it at that for now.
So I've also, as a researcher, been very much in the implementation fidelity is essential camp. And I think as I've worked with communities in my career and realized the extent to which there is a desire and a need to make adaptations. I think what is happening now, which I think is a good effort, is that some developers are helping communities and schools to think about ways that they can make adaptations that probably we as developers would think of as fairly minor, but potentially really important for their setting. And I think that's where the planned adaptation approach comes in. And I work on a drug abuse prevention program called Towards No Drug Abuse. And one of the things that we did after we did a large-scale dissemination trial of this program, we gathered a lot of information from teachers about their ideas for things that they said they did adapt in the course of implementing, and suggestions that they had for improvement of the program. And then there was a researcher at Berkeley, Emily Ozer, who also did some extensive interviews with teachers about this intervention. She came back to myself and the program developer, Steve Sussman, and took a look at all of the suggestions for adaptations, and we did a rating of them in terms of how consistent they were with the theory of the program, and we sort of put them in 3 categories. And so that then was built back into a revision of the program, building in some options for people so that if they looked at a lesson or a particular part of the program and said, the way it's written, form A of it isn't going to work, but maybe form B would. And I think there's probably a lot of smaller things that we could do in programs to make them more flexible in a planned and strategic way.
Luanne, do you think that many program developers would be willing to do that kind of work with us?
Well, I think many would. I think everybody wants to see greater uptake of their programs. They want to see population impact. And I think people are trying to find this balance between really strict fidelity and maybe some theoretically based adaptations that might be built into programs. And I think, another one of the challenges for many program developers is that we haven't done the research that we need to do to understand really what the core components are. And there's a lot written about this in the literature. There's a lot of discussion at all the meetings that I go to. So we need to do that kind of research, but I think there are also some things that we can do to build in some flexibility for these programs. And I think at least some developers are willing to do that and are doing it. Yeah.
Thank you. Okay. I'm not sure who was here first. Catherine, were you first? Okay.
Thank you for such a great presentation by all the panelists. My question is for Abby about CTC. In terms of people's access and ability to disseminate the CTC model. So my understanding is it was originally at the university and then was a publisher and then went to SAMHSA and I think has since moved. And while that probably is very interesting dialogue, how does that impact people's ability to access this model? And because it seemed like having a federal agency kind of disseminate it. So if you could talk a little bit about the dissemination of CTC and lessons learned through that process, how communities can actually access this model. And a somewhat related question is, when you all used to have your own compendium and now you've moved over to blueprints, and my understanding is there's a narrower list on blueprints than what you used to have. So how do some of these issues around dissemination impact the dissemination and scale up of CTC? So, thanks.
Okay, and I'll say I haven't been as involved with the effort from the University of Washington to disseminate CTC, so I'll do my best on your first issue. But, right, so during the midst of our trial, SAMHSA actually purchased CTC, and we were pretty excited about that from a dissemination standpoint because they were going to make and they did make all the materials online, but, free for communities to access and download. But, we talked about this a little bit, build it and they will come is usually not what happens, so people weren't instantly, widespread downloading of CTC didn't really happen. And like many programs or systems, just having the materials in your hand does not make for effective implementation. So CTC very much relies on having trainers and technical assistance providers help walk you through those phases. And it does take about a year of planning to get your coalition set up and thinking about these issues and to the point of implementing programs, and you want to keep the whole thing sustained. So as it stands now, this is the part I'm not entirely sure about, but now the University of Washington, they're trying to disseminate CTC through their organization as well. And they've also created some online training opportunities for community coalitions so that they don't always have to come face-to-face with the CTC trainer to get the technical assistance and training. That's really critical in this model too, because it can be used to train new coalition members as they come on board, or coalitions and community members are constantly changing. So this more fluid model of training, I think, is one that will help dissemination efforts and can be a little more cost-effective as well. So that's my answer to your first question. In terms of about why or how using the blueprints list has changed things a bit, one thing is that we are new evidence-based programs are emerging every day. It's very hard to keep up with what are the options available to communities. So CTC decided, why should we try to keep our guide updated when Blueprints is already doing this? So that's why they moved to the Blueprints list. In some ways it's more narrow, or in some ways it's broader than the CTC guide was, because Blueprints has expanded their focus. So now they used to be only interested in violence prevention and substance use prevention interventions. They've expanded to look at interventions to target teen pregnancy, obesity, mental health, which are usually things that communities are interested in too. So now communities have a wider range of programs to choose from. But the criteria are a little more rigorous to get onto Blueprints. And that's intentional so that the programs that are being touted as ones that should be replicated have the highest standards of evidence behind them, have the most rigorous research. And that's, from their viewpoint, we can't ethically recommend programs that have maybe only been tested once, and they might not work if they're tested in other kinds of environments. So, thank you.
Thank you.
Hi, Susan Kahn. I just, this is more of a general comment about moving from research into practice, and it has to do with determining the prevalence of bullying and assessing the effectiveness of programs. But I guess I'm concerned about the mindset that I think is influencing policy when you create when a strict dichotomy is created between the victim and offender of bullying, because at least in practice, I'm finding in mediations that there's kind of a fluidity there, and a bullying incident can be just like a snapshot in the stream of behavior that could be based on a very simple understanding. When you get kids in the same room, one of whom may even be suicidal because of the harassment she perceives as happening, you'll find out that, I just know of a case like this where an individual may find out that because of rumors spread, the so-called offender felt that they were victimized by the so-called suicidal, this other person. So, and there are other cases like that where one person, realized somebody knocked a backpack by accident. It wasn't intentional, but then verbal harassment happened after that. So you have cases where if you're trying to literally report on the incidents of bullying there, is there one victim and offender, one case there, or are there two cases? Because if we're relying on the perceptions of students to report bullying, the perceptions could be that there are two cases. And I think there are implications for how you organize the groups you treat. If you put someone in a discrete offender group too early, before you hear potentially the whole story, et cetera, you may skip over the opportunity to have communication happen where certain things are clarified. So I think there are really implications for determining, I wouldn't even know in the cases I'm dealing with, do I report, could this be considered one or two cases? Anyway.
Can you make it into a question for the panel?
Do you think that there is a strict dichotomy that should be established between having a victim and offender in a specific bullying case? Or do you think a bullying case could be reported as two cases if the main two individuals involved, for example, if it is two, both allege victimization or harassment by the other? And how would you, yeah, that's it.
Does anybody?
Being a twin, I sympathize with that, and my brother would probably too. I think we both felt offended many times with this one, and one of us would get caught. And I think it's this kind of dynamic that goes on that we often lose the context. And it sounds to me like the kind of program that you have in here, a mediation, is really that kind of opportunity to build and understand first of all, what those contexts are, to dampen down those kinds of anger, to get people to come together at the same time where they would be able to apologize or at least to reduce that, and do it in a way before it really incredibly escalates. And in urban settings, for example, those tit for tat kinds of interactions become gang wars that don't stop. And so I think that a strategy that is maybe even less focused around the counting, but on what that dynamic is, would probably be a useful thing. And it sounds like your program is really doing something like that.
Thank you. We have a patient questioner over here.
Hi, I'm Dr. Betty Lee Davis, and I live and practice in Pennsylvania. And I had first a question and then just kind of an information to provide in regard to policy initiatives in the state of Pennsylvania, and the questions for Abigail and what it is, since you applauded Pennsylvania for its implementation of CTC, what may have made the climate there receptive or what enabled that?
Right, that's a great question, because I've often, wanted to know that, because other states, if we want them to replicate this too, what was the condition? And really it was a champion at the federal, the state level, who learned about the CTC model and decided that, this was something that was going to be good for the state to implement. So it really just took one person with the resources and the opportunity to make that happen.
And was that person in?
Yeah, I'm totally blanking on the I think, I can't remember if it was the governor or the leader of the Pennsylvania Commission on Crime and Delinquency, or some combination thereof, but the larger political leadership, and then the state level people in charge of corrections, and realizing that we spend so much money on the correctional budget, if we can invest more in prevention, that would be a sound financial strategy.
Okay, thank you. And the information part has to do with House Resolution 191. I don't know if anyone in this room is aware of it in Pennsylvania, but it was adopted last April. It's declaring youth violence a public health epidemic and calling for statewide trauma-informed education. And its sponsor has taken it to the national level, where last August it was adopted unanimously nationally, declaring youth violence nationwide a public health epidemic and calling for the establishment nationwide of a trauma-informed education. So I just wanted to make people aware of that. It's certainly something. I provided the clinical information for the resolution, and Dr. Joan Duvall Flynn, who is the Pennsylvania Chair of Education for the Pennsylvania NAACP, brought the education perspective and combined. It led to a resolution. I have copies of it, a few copies for anyone who might be interested, and also through my recently having joined the ACES Connection. I don't know if anyone in this room has become affiliated with that, but that's another way to keep very informed about what's going on. And in the state of Vermont and Massachusetts, they too.
We have one more questioner.
Hi, I'm Ellen Schmidt from the Children's Safety Network. We're a resource center for injury and violence prevention. And we work primarily with state health agencies, but also in school agencies as well. But a lot of the discussion that we've had over the last 2 days are talking about fidelity, and I definitely agree with fidelity. We also have been talking about the Olveus program. We've also talked about the fact that Olveus hasn't been shown the same fidelity here in the U.S. as it has in Norway. Anyway, so when schools select that, and it's being selected all over the place, of things that they should do, including in Pennsylvania, which I think is the program that they selected. What are we asking them to do? Are we asking them to be true to fidelity with what Olveus said, or are we asking them to evaluate what they're doing in their particular location? And so I'm sort of curious about how are we going to distinguish between fidelity in a program and really evaluating it in the existing system. And I know that we were talking about the possibility of adaptation. I don't see how you're going to get around adaptation when every state, every community, every health agency is different. You're going to run into the need to modify it. So some suggestions, and then I have a tidbit, but if we don't have time, I won't share it.
I would just say that you're very strongly making the case for evaluation at the local level. As a field, we really need to understand how these models, when put into place on a wide scale, how they work, whether they work, and we need that kind of information. So in whatever way evaluation can occur with whatever funds, I think it's definitely what we need.
All right. That also goes to the whole issue of sustainability. So when we're talking about, we really need to know over time that we're evaluating something, schools and health departments don't usually have evaluators, not to mention local health agencies and implementers and a researcher to come in and help them move forward with the training or the evaluation. So the federal government certainly wants to put their money in for the trial, and then you guys do it over here, and then we're going to pull out. So how do communities and locals and folks, they still need resources. How are we going to pull those resources together for those? Where should they be looking in their community to gain the pieces that you suggest that they have in order for you guys to go back to doing research other than that? You know what I'm saying? And what you're suggesting they do to move on.
Well, I agree, and we've, we tried to prepare our sites for when we are no longer able to support your programs or your coalition. Where's that money going to come from? And the truth was, they did it in a large variety of ways. Are we out of time?
Yeah, we are out of time. Thank you very much. Join me in thanking the panel.